Hi everyone, and welcome back to Ravenscross Reviews about CVI. And today it's really a great honor to have Dr. Christine Roman-Lantzy today. How you doing, Christine?
I'm good, thank you. Hi, John.
Hiya. For those who've not watched, just a quick summary that these are one-stop takes. I tend to go and roll my eyes and things like that. So I'm not editing them out. I've got no editing skills. So please forgive if the Wi-Fi goes down a little bit as well. I'm in rural Edinburgh here, and my Wi-Fi is a little bit hazy. So Christine, great to have you here. It looks a beautiful sunny day where you are.
No, it's
No.
raining and
Oh,
gray.
isn't it really? All right. Well, it's gorgeous here. It's about 14 degrees. And for Scotland, that's hot.
Okay.
So I've known you for a long time now, Christine, and we're not in our 20s, and I'm really interested, as I ask all of our interviewees, really our chat people, what got you into CVI? What was it that made that change from being a TVI into CVI? I mean, it's it's a real big change and a real big commitment that we get into it. So what was it for you, Christine? What made that change?
Well, the change came gradually. It was really part of a process because as a teacher of the visually impaired early on, I'm also an O&M specialist and a child developmental specialist, mostly infants. But I had a caseload of children, birth to 21. This is a very long time ago. And when I was in my first year of teaching, I was assigned a residential place for children with really complex needs. And I had a caseload of children who had ocular visual impairment or blindness. And I went there and, was enjoying working with the kids. I actually fell in love with the place and with the children and the teachers. But they also the teachers began to say to me, Christine Roman, you're working with this child who has glaucoma. What about this child who stares at the lights all day? What about her? Are you going to work with her? And I would go up to the office and look through all of their records. And of course, I would find nothing that would qualify them as a child with visual impairment. And yet I did take them on because I agreed with the teachers. They certainly weren't using their vision typically, sometimes hardly at all. But the only tools I had were the tools that were designed for kids with ocular visual impairment. So I applied those tools and I tried to work very hard. I kept these index cards with goals and objectives and graphs on the back. I worked hard, but I was going in the wrong direction for sure. And and I knew in my heart of hearts that I wasn't effective with those children. And so even though the teachers were perfectly content with what I did, I knew it wasn't effective. So I had a few choices, and I figured I could either keep doing what I'm doing and nobody be the wiser. I could pass this caseload of children on to the next teacher, the visually impaired, who would be the next novice. I could try to maybe even understand these children. I thought, or I could try to fix this and understand this better. So that's what I chose. I began to look up everything I could about what happened, children with brain injury or brain conditions and vision. And I came upon the work of Dr. James Jan, who then became my mentor. Dr. Jan, as we all know, is a pediatric neurologist who published some of the earliest stuff around CVI. And he became a friend and a mentor. And I just held on to him like crazy. And he was extremely generous with me. And I learned a lot from him. But he wasn't an educator. He didn't do education in his practice. He did medicine. So I still had a lot of work to do. And so that's where I began to think, I've got to put all of my energies into understanding this. And I thought, well, and then I'll just meet all these other people who are doing the same thing, and we'll put our heads together and we'll figure this out. And I kept waiting and waiting and waiting for other people to, and back then in those early days, I'm talking about the late 1970s.
Oh, wow. Yeah.
I couldn't find anyone. I couldn't find anyone. So it was like trying to rub two sticks together to get a spark, but I was just one stick. And there was, so I just kept studying this, and I used it all the way through the work I did in my master's degrees and in my doctorate. and just made it just a real point of dedication. For me, John, it's really a problem that strikes two parts of me.
Mm-hmm.
And this is really true. It's really a problem, an intellectual problem that I love trying to solve. It's a head thing, but it's also a heart thing. And so when I began this work, all I wanted to do was be a better teacher. I didn't have any anticipation that using sort of a real organized approach would change anything in the child very dramatically. But I learned after a while, it really does. And so, and I'm not saying there's a cause and effect there. I'm saying there's a correlation and it only makes sense. You know, the more targeted you are, the more you're going to be able to help a child have access to their learning. So I've continued to take this on as this sort of dual thing, this intellectual problem I'm so fascinated by, and also the faces of these families who look at you and ask for help. And I can't, that's who I do this work for, is really for families.
Absolutely, and we'll move on to the support and the work you do in a second. I'm just a little bit interested in those early days. You know, because as you know, I talk a little bit about recognition, about data, and about, you know, even having it recognized in the International Classification for Disease and things like that.
Right.
And whilst I absolutely agree that this is not a condition that can be singularly described, right? You know, that absolutely is the case. You know, I'm interested in those early days when you were working with other professionals, and maybe Dr. Jan could help in those early days. You know, getting it recognized, getting it understood by the profession. You know, we're struggling with that now. So what was that like in the 70s and the 80s? I can't imagine, because I was only 12.
Right. And we were just inventing electricity. So
yeah. That's right. The wheel was somewhere there.
Yeah. So you know, it was very frustrating. It was very frustrating. And I remember sitting in staff meetings with my other vision colleagues, and they would say things like, we're not going to work with those children because, and this is a quote that just is seared in my memory, that I remember one of the other vision educators that we worked with at a staff meeting, she said, well, I'm not going to work with those kids because we work with children who have problems with their eyes, and the eye is not the brain. And so we're not working with the brain. So we only work with the eyes. And I thought, ouch, ouch, you know, like you can never separate vision and the brain, and it's all so completely synergistic. And I just thought, I don't know what I'm going to do. And I got a lot, you know, one of the things I've learned over the years, John, is to build a pretty tough exterior, because I feel like every step of the way, there have been people who've said, why are you doing this? You know, or vision's the least of these children's problems. Like, we don't need to worry about their vision. And I just have had to just push through. I've just had to push through. When I did my PhD, when I got my doctorate in 1996, part of the reason I didn't have too much trouble with my dissertation committee was because nobody else knew about it.
Right. Yeah.
Like, you know, and so I think today you could put a dissertation committee together that would be far more challenging. Now, I had some very, very, very smart people on my committee, so they really helped me research properly and do a study properly, but it was so odd to me. It was so odd. And so you can imagine my surprise today and my delight to see that you can fill a room or 2 or 10 with people who are actively doing this work. And that's so gratifying. It was really lonely.
Yeah, I bet. It's interesting. I'm examining 2 PhDs on CVI in May. So, you know, the world has changed. You know, you would have been the only years and years ago. That would be what's this? I'm not doing this.
Exactly.
All right, good. Yeah. What was it? Brain? No idea. All right. So, Christine. So, obviously, the range, great. And one of the things I really like about the range is that parental involvement. Is that the whole series of questions around parental knowledge. I mean, one of the things that I write about is seeing parents and children as experts, right? And for
Right.
me, that's a really important thing. And I see that the range is steeped in that. So do you want to tell me a little bit about that and tell me all about that parental knowledge and that parental support?
Sure. Sure. Well, the CVI range, the test that I developed to help sort of determine a level of CVI functionally and for educational purposes, that really came about because I had, it was all about parents, because I had a project at a school for blind children in Pittsburgh. I had I ran a baby project where young children would come in with their families. And when children came in with either a diagnosis or suspected CVI, it was so fascinating to me because their parents, when I would ask their parents questions like, well, tell me about, what your child likes to look at. I felt like, that movie Gaslight, I felt like they were gaslighting me because every parent would tell me things that were so similar. And I thought, have you all met before? Or how do you know to say this? And I realized what they were saying was critically important and probably diagnostic. And so I began to really collect up this information, and though the information they gave me not only told me something about these characteristics, some of which were Dr. Jan's, some of which were mine, and others, and I began to see that that these reports, what parents had to say, gave such a rich foundation. If you ask the right questions, parents they'll tell you pretty much everything you need. And so I always think of, the CVI range is based on observation, interview, and direct assessment. And there has to be agreement between those three things. But there is no CVI range without an interview. And when people think that they have conducted the CVI range by, asking the classroom teacher a couple of questions, they have not completed it. So when I had this project, I kind of began to see this process, and I said to parents, I think of CVI as being kind of like on a 0 to 10 continuum. It's not just one thing, and it has nothing to do with the level of other challenges a child has. Kids can walk and talk and be in gifted programming, or they can be in programs for kids with really complex needs. But the thing that's sort of the same is like how you can sort of see these visual behaviors, even though they play out based on other factors. And I would say to a parent, so I think today your child's sort of on this 0 to 10. I see them sort of 3-ish. And the next time they'd come back and say, last time you said my child was somewhere around a 3. Where do you think they are today? And I said, well, 4 to 5, I would say, maybe a lot of improvement. And then one day a parent asked the most dreaded question of all. And she said to me, what does that mean? And I said, it means I said so, that's all. And she said, well, I really want to know what went into you saying that. Like, what's the backstory? And I realized I really had to try to operationalize these levels. I had to try to figure out how the characteristics are not just one thing. They are many things depending upon many factors, but they can be defined. And so it was always parents. It's always been parents that have driven all of this. But nobody knows the child like the parent. Nobody. And I find it frustrating when teachers will say, well, we send notes home to parents, but they don't respond or what have you. It's our job. I believe it's our job to find a way to develop a relationship with families, no matter what other challenges there are. We're going to miss way too much information if we don't. I also want to say that in the CVI range, well, actually the interview questions were my dissertation.
Oh, okay. Yeah. Uh-huh.
And there was found to be a high degree of reliability between what a parent says and then in a separate room what an evaluator does. And that agreement between what the parent says about their child and what the evaluator sees relative to the CVI range, that agreement was had a p-value of 0.0001. So that's a big deal.
That's a highly significant score there. Yeah,
yes, and so that's a really important part of this whole process. And finally, the interview portion cannot be a questionnaire that is sent home, because parents will answer differently based on what they think you're looking for,
Sure.
perhaps,
Yeah.
as opposed to a conversation. A conversation is something so different, and it's spontaneous, and you can probe a little bit, and you can sort of like dwell on something if you need to learn a little bit more. It's a very, very different process. And so I also, really emphasize that a phone call's okay, but a face-to-face is ideal, and written out answers are not okay for my purposes.
Yeah, sure. Yeah, sure. And I think it's that it's nice that we got that conversation. It's getting that parental knowledge, like you say, just having a very formalized, I think, checklist. What we don't want is a checklist. There is that conversation with parents to get to really understand the parent and the child as well, and also, occasionally if the child is able to, to have that relationship with the child, I think is important too.
Right. Right. And I often say to people, these questions, the 25 questions that go with the CVI range, are a guideline. You don't have to, I've heard people ask, they'll take the paper and say, like, so it says in the book,
Yeah, here we go. Yeah.
Does your child, and they'll say, does your child, and they don't even use the child's name. They'll say, it's like, no, let's practice this. This is a conversation. And so you can ask more than that. You can't really ask less than what's there, but it's really meant to help a family feel connected, to let you, I feel like there's so much rich opportunity for families to it's almost like they've been waiting so long to tell you all this,
Yeah.
And they're almost amazed you didn't even know the right question to ask. Like, why did you ask if my child watches TV or notices TV? No, they don't. It's just very interesting. So I find it really one of my very favorite parts of doing the range. And the 3 components, observation, interview, and direct assessment, to come up with that composite score are equal parts. Like, the interview is not just a quick gimme. It's heavily weighted.
It's a core. Yeah.
Heavily weighted.
Yeah, and it's I mean, it's well used. It's becoming more well used across across Europe and Australia, I think. So, what are there any developments you're working on it, or are you? So what's happening with it now? Then that'd be really interesting to hear.
Yeah, so there are a couple things. One is I've written a clinical version for people in doctors' offices and places where they don't have time to go through the whole process, because it is for educational purposes, and it does take a while to administer and interpret. So I have a clinical one that is every single person would do it exactly the same way with the same materials. And I have 2 neuro-ophthalmologists and a pediatric ophthalmologist as 2 pediatric neuro-ophthalmologists and a pediatric ophthalmologist who are about to trial that and to see if they are able to, in a clinical setting, get consistent, scores.
Uh-huh.
And their goal is just to develop a phase. They only want to be able to place a child into phase 1, 2, or 3.
Sure.
And then once that is established, we're going to use that as a springboard then to do a replication study of the reliability of the range. So that's exciting.
Right. Okay.
Yeah. So again, there's that head part and the heart part. And the head part says, keep working it, make it better, make it better, make it better. And the heart part, is really about, I just really want to see families and do this and help them get a program started that will support their child. But really, in the end, it has to be both. I never thought I would be the head part. I mean, I always thought I would just be the heart part with the skills I learned as a teacher of the visually impaired. But what I've learned is that I learned this in my dissertation studies, that it really doesn't matter what I think or how much experience I have or what 1,000 people have told me. I have to prove it. I have to show it.
Yeah, you have to evidence it, and that's it. Yeah. Well, welcome to the world of academic research. Yeah, that's it.
I know, and I've grown to love it. Actually, I've grown to love it. I find it fascinating. I'm doing another study right now. I'm putting together 2 other things. One is I have data now on my infant screening. So we have a screening that's looking at very young children, and we have data now. And I've presented that in a couple big meetings, and it's very exciting.
And how young is young?
uh, babies who are 36 weeks of age through
Wow.
9 months of age.
Could that be young?
Well, we're looking for red flags. We're
Uh-huh.
looking for red flags that I believe show up very early. And those red flags then put the child in an at-risk category. And then the at-risk category, then that child's followed in developmental follow-up, and we do certain things. And then at between around 12 months of age, we do a CVI range. And if we're looking to see whether there's a correlation between the positive score on the infant screening and the first positive score on the range. If those two things are positive, it helps us understand that the screening's valuable. We
Mm.
have already identified a couple issues with the screening, and that's great because we're going to keep going. But we believe at the hospital where I have a clinic that we are not missing a single child. And I collect none of the data. They're collected by separate people.
Sure, sure. So
So,
blind to the study. Yeah.
yeah, it's very exciting. Like every time we identify another child very early and get them rolling with services, it's a very hard conversation to have with a family. But the data collector and myself, we sort of high five each other because it's like, we did it. We did it. We didn't miss that child. So
Right.
that's good. And then I'm working on my demographic study that of 660 children with CBI. Looking at I have all kinds of data, all
Sure.
kinds. So to look, just to kind of do an update on, what the cause is, what was the age of their diagnosis, what was their medical, other medical conditions, what services they get, and whether they have seizures, and then watching CVI range scores as well. There's a bunch
Yeah,
of
and
things.
time into service as well, because that's always an interesting thing, isn't it? So did they get in early? Was it, and how did they get into the services as well? I think that'd be fabulous to read that. But I'm just going to go back to that very early one because I think people who will be watching this will be going, John, why didn't you ask this? Why didn't you ask this? So I'm going to ask it, and whether it's too early to say or not, that's up to you, Christine, or not. So you talked about some red flags. What are the red flags in early? Are you able to say some of those red flags, or are you just still working that out?
So the red flags, there are 5 elements. There's only 5 things we test. It takes longer to talk about it than to test it.
Okay.
And it costs almost no amount of money. I have one regulated light that we have all the light properties on. And the rest of the equipment you need is a face and an index finger. And
No, I got one of those.
yeah. And so so we look at, and again, this is based on what nurses told me. When nurses would say to me, Christine Roman, come up here to the NICU and look at this child. This baby is just doing something weird in the NICU. And I'd say, what do you mean? And they'd say, well, no matter where we position her, she turns her head toward the light, no matter where we position her. What else? Well, she never looks at us, ever. And then we check to see if there's any, eye-to-eye contact. We look to see if the child defends themselves to a particular light. And we also see if there's a blink to touch. And then we ask 2 questions of their parent. If we look for, out of those 5 elements, if there are 2 positives, they are put into the at-risk category. Now, we only screen children who have the conditions associated with CVI. So, white matter damage, grade 3 or 4 bleeds, stroke, and so forth.
Yeah.
Those kids are all, those are the kids who are included in this. So obviously we're not including kids with acquired CVI. We're looking at kids who have congenital. And we just don't miss anybody. It's just a very exciting thing because it's just so easy to do. It's so easy to do. And you don't have to be a medical person to do it. So we have people that we've trained who are either part of the medical staff, like a nurse manager, or the developmentalist, the developmental specialist. And then they are, we have co-appointments in follow-up. So they schedule those kids for follow-up on days when I'm there. Now I'm hands off for a while, but if we really believe, before I'm ready to do the range, if we really believe this child is continuing to show traits of CVI, right from the first positive screen, we re-refer them to ophthalmology because they've all been seen
Yeah,
right
that's
away.
right. Yeah, because they're in the NICU. By the way, UK people, NICU, just in case you answer, is the neonatal unit.
Yes, right. And sorry about that. And so, but we re-refer them because and then we tell them why. But it's been an education, and now it's fascinating because the first phase of the study is over, but it's become just what we do now. It's just as part of the process in the NICU, so in the intensive care unit, and that's wonderful. It's just wonderful. It's very gratifying. So that's going on as well.
All right, excellent. And of course, then your big 650 data set as well. Gosh, just love to get my hands on that. But anyway, that's enough.
Play your cards right, John Ravenscroft. Play your cards right.
Well, you never know. You never know. I'll try and hassle you off screen and go, give us it.
Yeah. Oh, it's fascinating. I mean, because and it's pretty generalizable because they're kids from all over the world. They're not just Pennsylvania kids or Eastern United States kids. They're kids from all over the world, and that's kind of great, you know. And they're different. They have different backgrounds, different, you know.
Oh yeah. I'm gonna have a look at that data. I'm telling you.
It's very rich. Yes.
All right, so getting on to some other things. So the other thing that I teach on my CVI, so we have a CVI course here up in Edinburgh, as you know, and in fact you came, and one of the things I really try and teach on the CVI course, apart from what is CVI and how you assess it and things like that, is that collaboration, right? The collaboration of the TVI, the collaboration of the pediatrician, the ophthalmologist. It can't be you know, just a teacher thing. And I know the range is, you know, is for education, but the collaboration is a huge part of the range as well. So do you want to tell me a bit about how collaboration features in the work that you do?
Well, I will teach the CVI range to anybody, but I also know that I'm not an island. You know, I can't. It's so critical that we hear all voices and that all people be part of this, because if I were to create a set of recommendations and they had only to do with the time when the vision person's there, nothing would change. And so it's really about bringing everybody in, getting their points of view, and also really helping to create, you know, what I call a CVI schedule, which is a way to look at those accommodations across every discipline. And the more people we can, you know, engage. It's fascinating to me in the course that I teach for Perkins. I teach, you know, 2 online courses. They're full of all kinds of providers and parents, which is great. And I treat them all the same. Like, I feel like everybody has a right to the same knowledge, and everybody has a role in helping to improve this situation and help, you know, kids grow. So for example, you know, I can't imagine a child learning to use a gait trainer with their PT or physio and just move through space with no visual target, you know, like, so we talk about the importance of putting some visual target there, suspending a beach ball or having something that the child can actually move to and encounter. These are, you know, there's no way. Occupational therapy. How would you ever ask a child to develop better fine motor skills if you didn't think about making this visually accessible? So it's really communication. I do a lot of work with AAC people, helping to look at communication systems. And there have been some revolutionary ones for kids with CVI that have been phenomenal. So you know, my doors are open in all directions. I feel very strongly about that. Yeah. Sometimes parents, by the way, have the best ideas. So
yeah, that's right. Yeah, got to listen to what the parents say. So how about this? So I'm just I'm getting back to my very first question is, and it sort of worries me in a sense that whilst there are a lot of people working now in CVI, and we talked about, you know, I'm doing all these PhDs and stuff, who's going to come after us? What do you think? What do you think the future's going to hold? What's our future direction for us? You know, at the moment we're placed in this middle of the time. We're in a very difficult and awful and a terrible time. Yeah. But you know, this will pass and we'll move on. And you know, I think in a few years, where do you see the direction going? What's your crystal ball, do you think?
Well, I have no crystal ball, but what I really hope is that CVI will be identified in a fair and equitable way. That I really worry that a lot of minority children are not necessarily looked at the same way as children in, you know, sort of white middle class or upper class environments. And I know that's a really tricky thing, but I worry about that. And I worry that kids are misdiagnosed with things like autism and attention deficit disorder, when in fact they are undiagnosed. They have undiagnosed CBI. I talked to a girl yesterday in high school. She's 18 years old. And she said that she was asked to draw several versions of the Statue of Liberty and, color them a particular color that she can't even see. And she just like went under her desk and started to cry. And, this is not a behavior problem, and so those are the things I would like to see eliminated. I'd like to see people see, really see the children with CBI, identify them properly, and not think that this is another random behavior disorder, learning disability, cognitive problem that isn't linked to vision. I think it's so important that we put vision at the center of this. I also believe that there are going to be more and more and more people whose voices can be heard to make this whole process richer and to give us more and more choices of tools to use to help kids, whether it's combining, CBI with language things and AAC and, every kind of therapy you can think of. I think it's really important. I think we're just going to see it grow. And, I wish we could have a voice like some of the groups, like, I guess autism comes to mind. But I always say that the parents of kids with CBI are the busiest parents you'll know, because their kids have so many appointments and are so complex. So they don't often have a lot of free time to sort of just spend time organizing, but they will be the people that help move this forward. In the meantime, I think universities and lots of other lots of other entities are starting to get on board. And, I think the most lovely thing would be that someday my work is just a footnote at the bottom of somebody, doing something much greater. It's just a beginning, and I've been really honored to be part of this process. And it's just been a joy. It's been a joy and like I said, it's been a project of my head and my heart.
Yeah, absolutely. And if you were my student, grade A answer for that, Christine. I have to say, absolutely. Getting that, getting that identification equitable across the board. That's some of the work that I've been doing here in Scotland with my colleagues, with Vincip and stuff, looking at that for us, that ethnic minority group, but also the economic status as well. What we're seeing is the right middle class there, and also our research has identified that we're seeing a lot more CVI in parents and children from less privileged backgrounds. We're seeing a lot more of that. This could be due to diet. It could be due to a whole heap of factors. It could be maternal health and things like that, and we just need to really understand, which is why here's my plea for your data, you see, which is why if we can understand from this large data set, exactly what are these factors are, that we can maybe start to think about some proper public health outcomes, and really.
I agree. Yeah. I agree. And I think you're working, looking at what we would call zip codes. I don't, like where people live is really important. And I think if even my entire data set is a little skewed, because these are all volunteers that come to see me.
Yeah.
Now the infant study is not. That's different, because those are just all the babies in the intensive care unit. But the people who select to come see me, those 660 families that we have the data for, we have more kids, but I only use the data where we have complete data sets.
Sure. Okay.
Those families, they can afford to take the time to come. That's different. That makes a difference.
Uh-huh. Yeah, that's right. It does. And so it'd be interesting. Any new books in the horizon?
Well, my colleague Matt Tejan and I have completed a thing called the Sensory Balance, where I'm sure Matt's talked about that, in which it's kind of it is a learning media assessment for children with CBI, in which we are looking at ways to help bring all vision, hearing, and tactile learning all into balance. So we know that kids in what I would call phase 1, who hardly use their vision, that their vision is way out of balance with auditory and tactile learning. And so the goal is to try to help use all three and use them very specifically to help bring things ultimately more into balance, so that all through, and that's been really, really fun. And so it's a pretty quick system to use, but it's one in which, again, there's parent input, teacher input, the child themselves can have input, but it's a pretty dynamic way to look at when vision should take the lead, and when tactile or auditory should take the lead, and which one of those would be a support. And the thing that's different about it is that the assumption is that it will change over time as the child's vision improves, with improving functional vision as the ultimate goal. So that's fun. That's really been fun too with Matt. So that's done, and it's going to be published through Perkins, and it's already been peer reviewed and everything. But the last thing was to send it out for people to actually use it and give us their input, and that came to a screeching halt because nobody has students right now.
Yeah, that's right.
So,
yeah.
So I think it would be out now if it were, we've lost 6 weeks here. So
yeah, maybe longer as well, I think, maybe. Yeah, so we'll see that. All right, great. Well, I've taken up a lot of your time. I know you're extremely busy, but I'm going to give you an opportunity to, is there anything you want to say, or perhaps even ask me, or comment on anything?
I think I've said what I want to say. I just really appreciate the opportunity. I think anytime we can bring this international community together, I believe that that there's sometimes are misunderstandings about each other's work, but the only way you can push through those is to talk, is to understand, is to really take time to really be with that person and ask those questions, like, what the heck did you mean by this? Because I believe all of us are motivated by the same thing, and I think we should all, I think it's important. So thank you for doing this.
Well, I think we're all friends together. Like you say, we've all got really one thing at heart, and that's supporting families and children with CVI. And this is what we do. This is why we dedicate our time, our lives to that. And it's really, we are one family, really. That's who we are, and and that's what we do. We may take different directions, but that's okay. That's fine.
Yeah, it is okay. It is okay.
It is. That's fine. Well,
Okay.
It's been an absolute pleasure, Christine, as always. All right. I think you owe me a drink, but I'm still going to claim that one.
I'd be delighted.
Well, whenever this travel restrictions gets lifted, I'll be back over in the States, I'm pretty sure. So
yes.
I'll be going over hopefully towards Boston soonish, I think, to see the lab there, Karina, and so forth. But I'll short hop to Pennsylvania, really, not too far.
Right.
And just want to say thank you very much again, and I'm sure we'll be chatting again soon.
All right.
All right, take care, Christine. Cheers.
Enjoy your sunny day.
Thank you. I will do. Bye.